everyone. I'm very happy to join this session about obstetric APS, and I thank very much the organizers for giving me the opportunity to discuss with you about non-criteria obstetric APS. These are my disclosures. So we know that beta-2 glycoprotein 1 is the main antigen towards which antiphospholipid antibodies are directed. And this is very important to understand the relevance of non-criteria obstetric APS. And I'll tell you why. Because we know that placenta is full of beta-2 glycoprotein 1. So if a patient is carrying these autoantibodies, they will naturally bind to the placenta and exert their pathogenic potential. So obstetric APX looks like a different disease from thrombotic and vascular APS in this sense, because we know, and it is quite a well-accepted theory, the one of the second hit. So for vascular manifestations, we need to have a trigger, while for obstetric APS, the trigger itself is the placenta. And for a long time, it has been thought that thrombosis was the main driver of placental pathology in APS, but that's not the case. There are many non-thrombotic mechanisms that can be exerted by APL, and these are actually inflammatory mechanisms. And by learning more about the pathogenesis of obstetric APS, we can actually understand better why low-dose acetylsalicylic acid and heparin work well in this syndrome, because they have also some kind of anti-inflammatory properties. So what do we mean by non-criteria obstetric APS? There is this suggestion made a few years ago by the group of Hannah Cohen in London, and there are both clinical and laboratory criteria, like, of course, the criteria that we know very well. So for clinical criteria, we can have 2 unexplained miscarriages, 3 non-consecutive miscarriages, or late preeclampsia instead of early preeclampsia before the 34 weeks of gestations, or placental abruption and later premature birth, or turning to the assisted reproduction techniques, we can consider 2 or more unexplained in vitro fertilization failures. Turning to the laboratory side, we can consider as non-criteria those low positive anticardiolipin and anti-beta-2 glycoprotein 1 antibodies, or the presence of intermittent APL. We know that persistence of APL is one important feature of clinically significant APL, but it is common observation that there are women with these ups and downs in the presence of APL. So my task today was actually quite easy, thanks to this nice review of the literature. This systematic review of the literature went over the topic of non-criteria obstetric APS and made the comparison with criteria APS. As you can see, 8 studies were retrieved, and of course they were quite heterogeneous in terms of study design, number of patients, presence of healthy controls or not. But then as the authors of the SLR were able to highlight, there was actually a rate of adverse pregnancy outcomes that was not significantly different in criteria APS and non-criteria APS. Of course, both groups had more adverse outcomes than the general population, but still no big difference between these two groups. And when it comes to the response to treatment, it seems that standard treatment, so the combination treatment of low-dose aspirin and heparin, or even aspirin alone, is able to give good pregnancy outcomes in non-criteria obstetric APS. So it looks like that low titers of antibodies can be important when it gets to obstetric disease. And so I would like to discuss with you this very interesting algorithm, which is called Eureka, and that was developed by the group of Cecilia Chigizzola and Pierluigi Meroni in Milan, in Italy. So they took advantage of their very large cohort of prospectively followed pregnancies, and they collected many data regarding the patient's characteristics and the pregnancy outcome, and of course the treatment during pregnancy, which was tailored by the physician. And so they collected data on 147 pregnancies, of whom 155 were women with persistent APL at any titer, and 226 women with other autoimmune diseases but negative APL. So this was the control group. And so by using a model called generalized estimated equation, they were able to adjust the probabilities of pregnancy morbidities according to the APL titer and the APL profile, so the combination of the three criteria test. And so what was the output of this algorithm? It turned out that anticardiolipin IgG and IgM and anti-beta-2 IgM, either alone or combined together, they did not affect the basal risk of pregnancy morbidity, while the important tests were lupus anticoagulant and IgG anti-beta-2. And you can see it very nicely from these images. So on the left hand, you can see the different APL profiles, and each box has a different risk towards pregnancy morbidity. So you have a very basal risk, and then moderate, high, and very high. And then you can see the comparison between patients who had criteria APL and those who had low titer anticardiolipin or anti-beta-2 glycoprotein 1. So let's look of the chances for a good pregnancy outcome, for the reduction of pregnancy morbidity according to the treatment. So in green, no therapy, in pink, only low-dose aspirin, and in light blue, low-dose aspirin and heparin. And you see the dotted line. If the bar stays below, so towards the left of the bar, it means that the reduction of pregnancy morbidity is significant. And so you see the combination treatment was able to reduce the risk of pregnancy morbidity in both groups, so even in patients with low titer antibodies. Then another step was to consider the addition of hydroxychloroquine to the combination treatment. And again, you can see that this immunomodulatory treatment was able to yield a better pregnancy outcome in both criteria patients and patients with low titer APL. So this algorithm is actually very useful to assess point by point the risk of your patients according to the APL profile. And it shows how we can reach better outcomes by treating also non-criteria APL. But then another, let's say, special group of non-criteria patients are actually the APL carriers. So those patients who are found to be positive for APL by serendipity. So maybe while they're doing investigations for other problems, like for instance, infertility. And so these ladies are coming more and more to pregnancy clinics for counseling. And so we were able, together with the friends in Padova and Milan, to collect 62 first treated pregnancies in 62 APL carriers with no other autoimmune diseases. And we observed 13% of complications in these pregnancies. And as you can see, most of these ladies had a single APL profile, but still 15% triple positive. So APL profile that we can define as high risk for both vascular and obstetric complications. And these pregnancies were treated very differently. Actually, nearly half of them were not even treated. But then, by making a multivariate analysis, we were able to show that triple positivity was independently associated with pregnancy complications. So it looks like that these pregnancies were probably undertreated. Let's see, most of the patients received only low-dose aspirin. Only very few of them received heparin together with aspirin. So probably this tells us that we need to better assess the risk linked to the APL profile. But then also when pregnancies were treated with the full treatment, we still had complications. So this is another hint at maybe we need something more, even in APL carriers, which are most of the time completely healthy persons. So you will not be keen on giving them too many medications because they don't have any clinically relevant event in their history. And this problem of the management of APL carriers is something that it is actually still debated. I would like to show you the approach of the American College of Rheumatology. So this very nice algorithm shows you the approach in positive APL patients. But then if you don't have APS, so the criteria for APS, in other words, if you're an APL carrier, then they will recommend low-dose aspirin, but they conditionally recommend against heparin and hydroxychloroquine. This is actually quite a different approach if we look at the Euler recommendations issued in 2017. So Here, of course, these recommendations were based on expert opinions, but at the time it was quite a breakthrough to propose not only statements regarding the secondary prophylaxis of pregnant patients, but also primary prophylaxis. And as you can see in the black statements, the experts said, so if you have a patient with a high-risk profile, consider to use heparin for protection of your patient. And also the 2019 EULAR recommendation for the management of APS in adults got into the topic of the management of non-criteria obstetric APS. And we addressed the topic of clinical non-criteria APS, so either 2 recurrent spontaneous miscarriages or the delivery after 34 weeks due to preeclampsia. And then the experts wanted to recommend to consider the use of combination treatment or also aspirin alone according to individual risk profile. So again, there is a pinpoint on the approach towards non-obstetric APS as still women at risk of complications. But then why are we not so keen on treating non-criteria APS? Because we think we treat too much. Maybe we treat too much these patients and we will have bleeding complications, so we will turn wrong at the end. Actually, there are these 2 studies that can reassure us, as the major bleedings were very rare, let's say 3% in the American-French cohort and 1.8% in the European cohort. So I think this is very important because we can reassure our patients and also our colleagues from the risk of bleeding, and give an opportunity to our patients to receive a treatment that probably will allow them to have good pregnancy outcomes. So in conclusion, I would like to stress that women with non-criteria obstetric APS are at risk in the same way as criteria patients. And so we really need to have an individualized approach and to discuss with them in the preconception counseling and in the multidisciplinary team what kind of treatment is better for the single patient. And by thanking you for your attention, and I will be happy to take any question. I would like to thank also the colleagues working in the pregnancy clinic in Brescia. And I would like to invite you to the RumaPreg webinar, which will be held on September the 20th. And this is for free registration, and it's a nice occasion to keep updated with many topics, including antiphospholipid syndrome. Thank you.